Hi, everyone. Welcome. My name is Lauren Polk, and I'm the Senior Research Counsel at If When How, Lawyering for Reproductive Justice. And welcome to our session on the criminalization of abortion. Renee and I are coming to you today from the unceded land of the Piscataway people, also known as Washington, D.C. And before we get started, I want to do a physical description for you of myself. I'm a white woman with dark hair. I'm wearing a black turtleneck with a gold hexagon necklace with bees, hexagon earrings, and blue glasses. I'm standing against a beige wall with framed illustrations from the Repeal Hide Art Project and a mirror. I am just so pleased to be moderating this panel of brilliant people fighting tooth and nail to end the criminalization of abortion care. And please indulge me as I take a moment to introduce each of them to you. So Alice Wong, who uses she, her pronouns, litigates reproductive rights cases at the Center for Reproductive Rights. Prior to joining the center in 2019, Alice represented indigent parents charged with neglect and abuse as a staff attorney at Brooklyn Defender Services Family Defense Practice. And Alice graduated from Columbia Law School in 2017. And Tessa Benson, who uses she, they pronouns, is the co-director at Apiary, a national membership collective by and for groups that provide practical support to abortion seekers. For the past 9 years, Tessa has been personally and professionally immersed in the ongoing struggle for full, unrestricted access to reproductive care and believes the work must extend beyond legal protections. In their previous role as the helpline manager at the California Reproductive Justice Organization, Access Reproductive Justice, Tessa focused on building and strengthening relationships with volunteers, clinics, fellow abortion funds, and practical support organizations, community-based resources, and more to improve Access's service delivery model. She recognizes the immeasurable value and far-reaching impacts of strong relationships, and it is her goal to help build the connective tissue for Apiary's constellation of practical support resources. She believes in power and resource redistribution and centering those most impacted by reproductive and economic oppression, and champions those on the ground closest to the work. Dr. Jamila Parrott, who uses she, her pronouns, MD, MPH, FACOG, is a fellowship-trained, board-certified obstetrician and gynecologist and president and CEO of Physicians for Reproductive Health, a physician-led organization that mobilizes the medical community, educating and organizing providers using medicine and science to advance access to reproductive health care for all people. Dr. Parrott has a comprehensive background in family planning and has worked more than 20 years in the reproductive health rights and justice spaces. She provides on-the-ground, community-based care, focusing primarily on the intersection of sexual health, reproductive rights, and social justice. In addition to her work as a clinical provider in the Washington, D.C. area, she has led PRH since 2020. Dr. Parrott serves via mayoral appointment to Washington, D.C.'s Maternal Mortality Review Committee. She is a fellow of the American Congress of Obstetricians and Gynecologists, ACOG, and serves as chair of ACOG's Committee for the Health Care for Underserved Women. She is a member of the Society of Family Planning, serves on the All Above All Steering Committee, and is a member of the Black Maternal Health Federal Policy Collective. Renee Bracey Sherman, standing with me, who uses she, her pronouns, is a reproductive justice activist, abortion storyteller, and writer. She is the founder and executive director of We Testify, an organization dedicated to the leadership and representation of people who have abortions and share their stories at the intersection of race, class, and gender identity. She is also an executive producer of Ours to Tell, an award-winning documentary elevating the voices of people who've had abortions, and the co-author of the forthcoming book, Countering Abortion-Splaining, from Amistad HarperCollins. So now that you're all extra excited to be hearing from our panelists, I want to set up our discussion for the day. So first, I'll ask Ms. Wong to discuss the abortion case currently at the Supreme Court and what's at stake for abortion laws across the country, in addition to the September denial of an emergency order to stop a law in Texas, SB 8, that bans abortion at 6 weeks of pregnancy and calls on everyday citizens to enforce the law and to profit from that enforcement. Second, Dr. Parrott will help us understand the challenge this legal landscape poses to abortion providers and how healthcare professionals can fight back against the criminalization of their patients. Then I'll ask Ms. Benson to explain how this legal landscape and abortion criminalization in general affects practical support for abortion care, and how identity and oppression also affect access to that care. I'll then ask Ms. Bracy Sherman to share her work with abortion storytellers and, as a storyteller herself, how the criminalization of abortion impacts our collective ability to mobilize for change. We'll then move into a Q&A session, so please submit any questions you have as we're speaking, and we'll note them down. We'll close with a visioning exercise, because though we're talking about heavy things, dreaming and planning is often the most important strategy and self-care that we have. With that, Alice, my first question for you concerns the case currently at the Supreme Court. So can you tell us more about what that case is about?
Sure. Thank you so much for teeing up this discussion, Lauren. And to start with a brief physical description, I am an Asian woman with long black hair, and I'm wearing a navy top, and there is a plant behind me. So I am part of the team representing Jackson Women's Health Organization in the case currently pending before the Supreme Court. This case involves a challenge to Mississippi's ban on abortion after 15 weeks of pregnancy, and it's the first time in a generation that the court will hear a direct challenge to Roe v. Wade. To provide a little bit of context, Roe established constitutional protection for the right to abortion almost 50 years ago. In the 2 decades that followed, there were several attempts to overturn Roe, but the court repeatedly reaffirmed Roe's central holding that each individual has the right to decide whether to continue or terminate a pregnancy prior to fetal viability. For many years, anti-abortion politicians focused on an incremental strategy of passing laws designed to push abortion out of reach, even with Roe on the books. These include laws that single out abortion providers for onerous, medically unnecessary requirements, and laws that force people seeking abortion to jump over hurdles that are insurmountable for many, especially those who are low income, who are disproportionately Black, Indigenous people of color, as well as undocumented people, young people, people who live in rural communities, and people with disabilities. Since the Supreme Court's composition changed in 2018, anti-abortion politicians have become increasingly emboldened in passing outright bans on abortion at earlier and earlier stages in pregnancy in order to set up a direct challenge to Roe. Mississippi's 15-week ban is one such law. There's no dispute that 15 weeks is months before viability. The question before the court is whether all pre-viability bans on abortion are unconstitutional. And under the court's existing precedent, the answer to that question is undoubtedly yes. So Mississippi is explicitly asking the court to jettison almost 50 years of precedent and strip away constitutional protection for the right to abortion. It's impossible to overstate the stakes of this case and how critical this moment is for the reproductive health, rights, and justice movement. As I mentioned, abortion has been pushed out of reach for so many people, even with Roe on the books. So preserving abortion's legality is not sufficient to guarantee access to abortion. But even this bare minimum is on the line and at graver risk than it has been in decades.
Thanks, Alice. I wonder if you can also speak a little bit to how the SCOTUS case is going to affect access to care, right? Like, what are the different outcomes that might happen, and how might that care potentially be criminalized?
Absolutely. So access to abortion care will be devastated if the court upholds Mississippi's 15-week ban. I'll start with the impact within Mississippi. Our client, Jackson Women's Health Organization, is the last abortion clinic standing in the entire state. All the others were shut down by Mississippi's campaign to target abortion providers for medically unnecessary regulation. So abortion access in Mississippi is already exceedingly limited. At the same time, Mississippi has the highest poverty rate, the highest percentage of Black people, and one of the highest maternal and infant mortality rates of any state. So allowing Mississippi's ban to take effect would deny abortion access to people seeking to terminate their pregnancy after 15 weeks, with the greatest impact on Black women and this would perpetuate the state's long history of reproductive oppression. Now, zooming out to the national impact, there's no path for the court to uphold Mississippi's ban without overruling Roe. As we've argued to the court, there are no half measures here. So long as Roe survives, Mississippi's pre-viability ban cannot, and vice versa. If Roe falls, almost half the states in the nation will move to ban abortion. A dozen, including Mississippi, have what are called trigger laws in place that are designed to ban abortion immediately if and when Roe is overruled. Others have pre-Roe abortion bans on the books or are poised to pass new bans. All of this would leave a large swath of the country, mainly across the South and the Midwest, without access to legal abortion care. The reality is that people with means would still be able to obtain abortion care by traveling hundreds or even thousands of miles, but people who can't afford to take that time off from work and to pay for transportation, lodging, and childcare will be denied access to abortion care. Those folks will be left with the options of attempting to terminate their own pregnancy without medical supervision, which Dr. Parrott will discuss in greater depth, or carrying their pregnancy to term and undergoing childbirth. And those most impacted will, again, be Black, Indigenous people of color, young people, undocumented people, and people with disabilities. As for criminalization, many abortion bans impose criminal penalties on abortion providers. They generally don't criminalize the person seeking abortion, but they contribute to abortion stigma and confusion about the legal status of abortion. And that in turn increases the likelihood that overzealous prosecutors will target people who have had an abortion and even people who've experienced a miscarriage or a stillbirth for criminal investigation and arrest. Such criminalization is already happening even with Roe on the books, and it would likely become even more common if Roe falls. And that's because Roe protects more than the right to abortion. It makes clear that people don't lose their bodily integrity and their autonomy upon becoming pregnant. That principle helps to safeguard pregnant people from being criminalized for refusing unwanted medical treatment or any number of actions or omissions that can be perceived as potentially harmful to a fetus. So gutting Roe could lead to even broader criminalization of pregnant and postpartum people. And once again, those impacts would fall hardest on Black, Indigenous people of color who are disproportionately impacted by the criminal system.
Thank you so much, Alice. It's a sobering and comprehensive summary of what's happening at the Supreme Court and what's at stake for all of us. I want to see if you can cover something else that I know is probably in the forefront of folks' minds because it's been in the news so much, right? The law in Texas that was passed in September, Senate Bill 8. Can you talk more about what this law is and what it does?
Yes. So as Lauren mentioned, SB 8 bans abortion upon detection of embryonic cardiac activity, which can be as early as 6 weeks of pregnancy. What sets it apart from other abortion bans is that it outsources enforcement to the general public. So it authorizes any vigilante to sue not only abortion providers, but anyone who aided or abetted a banned abortion or even intended to do so for a minimum of $10,000. This bounty hunting scheme and SB 8's other cruel features are designed to evade judicial review and to weaponize the judicial system for intimidation. And that's exactly what it did when the law went into effect on September 1st. Abortion clinics across Texas stopped providing abortion after approximately 6 weeks, which is just 2 weeks after the first missed period. And it's before many people even know they're pregnant, especially young people, people who are on birth control, and people with irregular menstrual cycles. So the ban effectively precludes about 85% of all abortions, and Texas providers have been forced to turn away the vast majority of Texans seeking abortion. Clinics in surrounding states like Louisiana, Mississippi, Kansas, and Oklahoma have been overwhelmed with patients from Texas, and they're backed up for weeks. Those backlogs then force Texans to travel even further and create a dramatic ripple effect across the entire nation. There have been numerous reports of Texans having to drive hundreds of miles across multiple state lines, and Texans faced with weeks-long waits for an appointment in another state which can result in being pushed beyond the window that medication abortion is available, or even being denied abortion altogether. Turning now to the multiple challenges to SB 8 that are currently pending. Before its effective date, a number of abortion providers, funds, and other advocates challenged SB 8 in federal court and asked the district court to block the law. But a few days before the court was scheduled to hear that request, it issued an order that the defendants appealed, and then the Fifth Circuit Court of Appeals hit pause on all of the proceedings before the lower court. So that canceled the scheduled hearing, and it prevented the district court from blocking the law. We then filed an emergency request with the Supreme Court asking it to block SB 8 before it could be enforced. But the law took effect at midnight on September 1st with no action from the court. And about 24 hours later, the court denied our request on a 5-4 vote. Its order pointed to what the court deemed complex questions of procedure raised by SB 8's enforcement scheme, but it made clear that the court wasn't ruling on SB 8's constitutionality. After SB 8 went into effect, the Department of Justice filed a separate federal lawsuit against Texas and also asked the court to block SB 8. This is remarkable because it's the first time the federal government has sued a state to enforce the right to abortion. The district court heard the DOJ's request last Friday, and thankfully, last night it issued an order finally blocking SB 8. The district court had no trouble seeing through Texas's attempt to insulate its flagrantly unconstitutional law from judicial review, and it concluded that it, quote, would not sanction one more day of this offensive deprivation of such an important right. So independent clinics across Texas are working to resume providing abortion beyond 6 weeks, but Texas has already appealed the district court's injunction. And one of the pernicious features of SB 8 is that if the injunction is lifted, people can be sued for providing or aiding abortions performed even while SB 8 was blocked. Finally, our client, Dr. Braid, who has been providing abortion care since the 1970s, courageously performed an abortion in open violation of SB 8, and 3 lawsuits under SB 8 were filed against him in Texas state court. We brought another federal case on Tuesday asking to consolidate those 3 lawsuits and also asking for SB 8 to be declared unconstitutional. So there are a lot of moving pieces and things are literally changing day by day.
Thank you so much, Alice. I know I'm not just speaking for myself when I say we have so much gratitude for the work that you all have done to try and make sure that these laws are challenged. And we just really, really appreciate that. I want to take a moment to say that. So another thing is that we know that folks have started to try and isolate Texas and say that this is just a Texas problem, right? That this isn't happening in other states, that this is something that we just, people have said really offensive things, right? Like Texas needs to secede or, things like that. And there are a ton of people who live in Texas who need access to care and are really, really being affected by all of this right now. And so, Tessa, I want to turn to you next and ask, how is access to abortion impacted by identity and oppression and zip code, right? All of the things that we think about whenever we're thinking about the different things that impact the ability of folks to actually access care.
Yes, thanks, Lauren, for facilitating this conversation. And a quick physical description of myself before I get started. I'm a multiracial Latinx person with dark, curly brown hair, collarbone length. I'm wearing some big, bold yellow earrings and a blue and white striped blouse. And behind me is a white wall with a few paintings that will hopefully be filled up more in the coming months. But this is a great question, Lauren. So practical support helps people fill in the gaps when accessing care, accessing abortion care specifically in this context. And it's meant to remove as many barriers as possible, but there's always a spectrum of how complicated those barriers are. Practical support work is overwhelmingly complex, and many people, myself included, don't really understand just how complicated it is and how nuanced it is until they start providing it and asking those questions. So practical support organizations, something that I'm going to shorthand to PSOs throughout this conversation, um, are constantly working with abortion seekers to find workarounds to these barriers. And there's just an endless array of considerations that must be taken into account in terms of identity and what are other barriers that people face. For example, trans, non-binary, gender non-conforming folks, they can experience harassment when traveling related to discrepancies, in quotes, with their IDs. Often they have to travel through very LGBTQI plus hostile areas. Undocumented folks and formerly incarcerated folks who need to travel out of state, that's a barrier. Sometimes there are border checkpoints and they're not allowed to leave the state. Um, Transportation options for people with disabilities are often limited and cumbersome. Childcare is expensive and often requires ahead of time planning, which not everyone can make work. Options for direct cash assistance, for example, are really limited for people who don't have bank accounts without valid photo IDs. BIPOC people face the most rampant income inequality and are more likely to be covered by Medicaid as a result, which severely impacts their ability to access abortions when those federal funds won't cover the procedures, and neither will the states. So on and on and on. Like, there's just an overwhelming amount of barriers that people face. And practical support organizations, PSOs, exist in direct response to these systems that fail people, right? For example, I'm based in California in the Bay Area, and out here we have something called a Medi-Cal program called non-emergency medical transportation, and that program theoretically covers rides to and from non-emergency medical procedures. So, dentist appointments, running to the pharmacy, having an abortion at a clinic. But the issue with this is, people, depending on the managed care provider that will provide this transportation, they have to get the doctor's note ahead of time. They have to book and confirm the transportation vehicle or option, up to 7 business days. And people seeking abortions don't always have the luxury of all of that time to plan. So a lot of the time, this is a perfect example of a system theoretically that supports people, but ultimately fails in practice a lot of the time.
Thanks so much, Tessa. I think practical support organizations, or PSOs, are not something that a lot of folks who are outside of the repro movement really know about. So I think it's so important for folks to understand what those are, to spread the word that they exist, so that folks will know about this avenue to access care, and will also know where to direct their dollars if they're looking to really support folks on the ground. So can you talk a little bit about why or how practical support organizations have been impacted by this legal landscape that we're seeing right now?
Yeah, absolutely. And I'll give, I so appreciate that you bring up the fact that many people outside of repro spaces they don't really understand what practical support is. So I'll give a little bit of context and then I'll get into that question. So practical support is any kind of support that helps someone obtain the care that they need. And in abortion access, this looks like lodging, local and long distance transportation, childcare, meal support, funding for these services like bus tickets and gas money, et cetera, and just so much more to help people access clinic-based and non-clinic-based care. And practical support is not new, right? Communities have been providing this support for one another for as long as we've been living in organized communities, whether it was called practical support or not. And so this exists in many spaces, not just in abortion care. And I would argue that a lot of us know what practical support is outside of abortion care, right? This can look like supporting friends who just had a baby with DoorDash tickets, right? Or dropping really easy meals off to your friends who are having a health issue or going through something really stressful, right? All of that encompasses practical support for our people, for our communities. And we need the funding and we need the policies in place. But if people cannot physically get to the clinics or physically obtain the pills to self-manage, the funding and the policies are kind of moot, right? And more people are learning about practical support and are eager to support and get involved, which is great because we kind of need all hands on deck for this. And practical support in many ways was and is this kind of silent backbone of abortion access. But PSOs wouldn't need to exist if there were adequate social support systems in place. So even people calling the hotlines themselves, abortion seekers calling on funds, calling on PSOs for support, sometimes don't realize practical support exists. Practical support has flown relatively under the radar, but incredibly restrictive laws like SB 8 in Texas, as Alice kind of walked us through, specifically targets the providers of practical support. So as Alice mentioned in the bill, the bill includes language around aiding and abetting someone who is seeking an abortion, which includes supporting someone with a ride, securing housing for someone, supporting someone with childcare while they obtain an abortion, and more. And that is the work of practical support organizations. So SB 8 is this really unprecedented attack on that work, and laws that are copycat laws that may or may not be popping up in other states around the country. This will have a domino effect and have a ripple effect on these practical support organizations providing this care that is starting to get targeted because more people are finding out about it, which is great for abortion seekers and also kind of gives more opportunities for antis to continually pick away at abortion access at large.
Yes, and just some movement insider knowledge. When we say antis, we're talking about anti-abortion folks. It's our little shorthand for them. So thank you so much, Tessa. I think it's really great to know that practical support organizations are out there, and I think it's such an act of hope to be a part of and to contribute to practical support organizations. It's us saying we know that we've got us. Right? We're going to support each other unless and until there are more formal systems of that support. We're here and we aren't going away. So thank you so much for that. So Jamila, I want to turn to you to talk about something that, again, also has been in the news, right? Might be something that not everyone is aware of, but has been mentioned on the panel already today, right? That when folks cannot access abortion in clinic, or simply because they don't prefer to access abortion in clinic, right? There are many reasons. People might self-manage their own abortion care. And I'm wondering if you can talk more about what self-managing abortion is, and whether it's a crime, whether it's safe, right? I know these are all questions that folks probably have when they hear about self-managed abortion. So please take it away.
Yeah, sure, absolutely. So I'll start with the description as well. I'm a Black woman. I have big curly hair and a brightly colored headband on, turquoise, and there's some orange in there as well. I have on a shirt with probably 1,000 pleats on its sleeve. And also there's a bright picture behind me of someone carrying a child on their back with lots of yellow and red. So I'll start with, I think before I go into the question of what self-managed abortion is, I think I want to start with really a grounded understanding in the fact that abortion has always existed for as long as people have been getting pregnant, they've been having abortions as well. And so as long as abortion has existed, the desire, the willingness, the ability to manage your own abortion has also existed. I think this phrasing of self-managed abortion, the fact that we call it something specific now makes folks think that it's brand new, but it absolutely is not. And so I think that that's a really important place to start because it helps people understand this question around safety. When we're talking about self-managed abortion, what we're really talking about is folks who are accessing abortion care outside the traditional medical system. I'm an abortion provider based in DC, and so the abortions I provide are clinic-based abortions. And so I take care of people in that space. But I also know that for some folks, they are unable to see me in the clinic or unwilling to see me at the clinic. Some folks will always want to be able to access clinical-based care, and some folks will never want to access clinical-based care. And so when we think about our broad understanding and framing of abortion access, self-managed abortion has always been there. The tricky part when we talk about self-managed abortion is that in our advocacy to support clinic-based abortion and the reproductive rights movement, so much of it has really been grounded in concerns about harm and danger and safety. And so the narratives that we often hear, have heard historically around self-managed abortion have been ones that rely on coat hangers and back alley abortion narratives, because that's what we've been used to discussing in hopes of saving clinic-based abortion care. Self-managed abortion looks very different now than it did 30 years ago, 40 years ago, 50 years ago. And that's a really important distinction to make. And so much of that difference relies on the availability of things like medication abortion, or the medicines that we use for medication abortion. For folks who are using medications, the same medications that we use for medication abortion to manage their own abortion, there is no difference in whether you access it from me or you access it outside the medical system. It's the same medicine. And so the safety is the same. So whether I'm handing it to you or you've accessed it in other ways, it does not change the safety profile of the abortion in and of itself. We actually know from really strong and robust evidence that when people have the right information, when they have resources, access, and the ability to get help should they need it, in the rare cases that they need it, self-managed abortion is very safe. So typically when we think about self-managed abortion, we're thinking about it in the context of the medications that we're most familiar with. But it can also look other ways. So people manage their abortion through herbs and tinctures and other things that we haven't studied as robustly as we have in the organized medical space, but that doesn't make them good or bad or right or wrong. So much of this is grounded in personal preference and cultural frames, things that we don't understand. And our tendency in the medical space is to say, if we don't understand it, it must not be safe. And I want to say very clearly that that's not necessarily true, right? So that's the first part of it. The second part that you didn't answer, but I'm going to answer anyway, is why, right? Why do people manage their abortion? Because I get that question a lot. And there, as you mentioned, Lauren, there are a number of reasons. Some people are managing their abortion because they can't make it to the clinic, right? So clinical-based abortion care is unavailable to them. And so we see this happening in places like Mississippi, in places like Texas, but we also see it happening in places like Ohio and Pennsylvania, in rural communities, right? On native lands, clinic-based abortion care may not be available. Another reason why someone may self-manage their abortion is because clinic-based abortion, although it is available, it is inaccessible, right? And that happens even in urban areas. And so if you live in a neighborhood that does not allow you to have reliable transportation, if you don't have money or resources, if you don't have practical supports that Tessa mentioned, then the presence or absence of an abortion clinic means nothing because it is inaccessible to you. If we're talking about young people and you live in a state where there are parental notification or consent laws, clinic-based care is there, but it is inaccessible to you, right? And then the third way I think about and talk about reasons for self-managing abortion is if clinic-based care is unacceptable to you, right? And so it may be available, it may be accessible, but you may prefer to care for yourself on your own. So for some folks, managing their own abortion is more convenient. It feels more natural to them, more like a miscarriage. I don't want to walk through the thousands of protesters that stand outside the clinic that I provide care. So I know that the people we care for don't want to either. And that is and should be unacceptable, right? For many folks. So that may be another reason why. And then also, I just want to go back to that last piece about the fact that this is a practice that has occurred in many cultures for centuries. And so the idea that you would go to someone you don't know out of your community to get care in this way is not something that resonates with everyone. And so clinic-based care is also unacceptable for folks in those cases too.
I'm so glad you went into the why. Thank you for doing that. I think it's really important that folks understand that there's really myriad reasons why someone might choose to or decide to self-manage their own abortion care. So I have a tricky question for you that I think folks might have, right? Is self-managed abortion a crime?
So I'm going to lean into all of the time I've spent with the if, when, how lawyers when I say that what are they? Correct me, Lauren. Only 4 states where it's on the book. Is that still the truth?
That's
So I think that one of the messiest parts of this whole conversation is that there's a lot of confusion around legality. Right. And what's happening in Texas makes it even more confusing because we're thinking about criminal penalties and civil penalties. And I'm not a lawyer. And so digging into that is certainly not something that I would venture to do. But what I do know is that for folks who are or who have been criminalized, and this is where I enter the story with my white coat and my stethoscope on, right? For folks that have been criminalized for managing their abortion, it is often because of their interaction with the medical system. And so we want to be really careful when we talk about what is legal and what's not legal and what is reportable and what's not reportable and how we hold our community in a way that gives them the support that they need and does not put them at risk for surveillance and criminalization. So I'm going to defer to the lawyers about legality. But what I will say is that we have not just an opportunity, but an obligation as healthcare providers to make sure that our folks are as safe as they can be, and that we're not causing harm or contributing to their risk of criminalization in any way.
Could you talk a little bit more about that? So how can providers help fight criminalization? What can healthcare providers really do to show up in this moment, knowing that people are and have been criminalized for self-managing their own abortion care? What are some of the things that providers can do?
Whether we're talking about abortion care or not, the number one thing that providers can do to avoid criminalization is stop calling the police on people. And so that is on a period. And so whatever the issue is, let's begin with that as our framing. When we talk to providers, one of the things that is super confusing, I think, to folks is this mandatory reporting piece. So sometimes folks who have been thrust into the criminal legal system because of their interactions with the healthcare system and healthcare provider that's occurred because of malintent of some providers. It's also occurred because of confusion. Is this something I'm supposed to report? Is this something I'm not supposed to report? I'm not sure, so let me just report it. Better be safe than sorry, right? But we do know, whether we're talking about the legality of self-managed abortion or not, there are no, I'm going to say it very clearly and slowly, there are no mandatory reporting requirements for healthcare providers for folks you've suspected of self-managing their abortion. There is no mandate to report this. There is no mandate to report this. And in fact, it actually goes against our ethical principles as healthcare providers and privacy protections. So for all of the confusion, we're doing it wrong, right? And so number one, just as a rule, don't call the police on the people that we care for. 2, think through ways that we can provide support, really interrogate what your concern is and how you can provide support for these folks. And so those are really important keys. So what happens is that, all of these laws really come together. And whenever you see places where the criminal legal system and healthcare overlap, what you don't get is wellness. You don't get health. You don't get wellness. You don't get care. There is no circumstance or situation where the criminal legal system should be integrated or conflated or collaborating at all with the medical system. And so as healthcare providers, we have an opportunity to stand in that gap and to understand that our obligation, our responsibility is first and foremost to the people that we're caring for and the community that we serve. And if you approach all of your questions in that way, then the police are never the answer.
Thank you so much, Dr. Parrott. We did have a question come in while you're speaking, which is, from your experience, what are the main factors that contribute to your patient's choice to get an abortion outside of it being their choice?
So that's an interesting question, right? Because the word choice showed up twice in that question, which I think is really interesting. And what I'm going to do is sort of pull on that thread a little bit, if you'll permit, because choice is a false construct for many people. right? Everyone's choice is not the same. They're not viewed the same. They don't happen under the same circumstances. And they are not judged or evaluated the same. And all day, not just in abortion access and not in the way we're making our decisions about carrying a pregnancy to term or not, parenting or not, we all have this hierarchy of choice that we're making. And so much of it is shaped by our access or lack thereof of support and resources, right? And the external threats of oppression in our lives. And so, I don't know that there are any main factors. People who are managing their own abortion or who are seeking abortion care outside of the medical system are doing it in the context of their lives. And they have to assess the risk benefits for themselves and then make a choice based on all of those circumstances. And so it may be because it's unavailable. They can't get to clinic-based care or they can't access those services. And it may be because it is part of their normal cultural practice. What we don't want to do and what we really want to resist the urge to do is to try to find a single story in this. That isn't a thing. It doesn't exist. Every single person that I take care of is different. Their story is different. Their experience is unique. Their reasons are different should they want to share them with me, right? And so there is no single story there. And so I resist the urge to tell one because I think people deserve to tell their own full and complicated stories themselves.
Speaking of stories, I want to go ahead and start with a question for you, Renee, which is, what is the reproductive rights, health, and justice movement doing to respond to these attacks that we've been hearing about? And how does the threat of criminalization impact what we do? And specifically, how does it impact what you and your storytellers do?
Hi, everyone. First, I'll give a quick description of myself. I'm a biracial Black woman. I've got dimples in my cheeks and my chin from my mama. I have curly brown hair. I'm wearing gold glasses, standing next to Lauren here in her house with all her beige walls and beautiful art. And I've got on a Black t-shirt that said, "I had an abortion," in lowercase letters. So what is the reproductive health rights and justice movement doing to respond to these attacks? Well, we're doing a lot, right? As Tessa mentioned, we're trying to actually make sure people are able to get their abortions in as simple a way as possible without dealing with so much stress. As Dr. Parrott talked about, we're providing those abortions, whether it's through community care and doulas and midwives or physicians and nurses in clinics. And as Alice pointed out, that we're litigating, right? One of the things that those of us who've had abortions are trying to do is actually get the movement to shift our conversation and that we actually talk about it more in a proactive way, because for so long we have been responding to attacks, which means that we're fighting and arguing about things in a frame that is created by the anti-abortion movement, that is created by politicians who want to eradicate abortion altogether, those who are attacking it to begin with, right? So we're both trying to do defense, but also push a vision of what it is that we want. What is the care that we want everyone to have, the experience we want them to have, and make sure that we actually interlock the issues, that voting rights is not separate from abortion access, which is not separate from environmental justice, which is not separate from maternal health, which is not separate from disability justice, right? All of those things come together. But that also then means that we have to dig deep and really understand how criminalization works here in the United States and around the world, particularly through white supremacy, anti-Blackness, anti-Indigenous sentiment and policies, and also just like global domination of the United States and how our armies and police show up in communities and around the world and enforce a lot of these anti-abortion policies. One of the things that people forget to talk about is that every 4 to 8 years, when we switch and we have the global gag rule and all of the Hyde and Helms policies internationally, that means that U.S. dollars aren't allowed to cover abortion services that around the world. That then leads to criminalization and less safe care for folks around the world, not just here in the United States. And then, of course, the United States supports policies around the world that increase criminalization here and abroad. So our movements are really trying to shift that conversation to understand that it's more of a global one, that it is based in racism and anti-Blackness, capitalism, and the presence of police all across this country and around the world. It's really complicated. And I'm just going to say and be honest, because there are people within the field, within the movement, who benefit from the presence of police and capitalism and all of those things. So the reality is that we are at this moment where that's why the 3 different frameworks exist, right? And we are pushing all of our movement to understand that racism and capitalism are at the core of all of this. Anti-Blackness is at the core of all of this. And that we cannot both be inviting police to our protests and then be upset when police are arresting people seeking abortion care. It's all part of the same liberation.
Thank you, Renee.
You're welcome.
So I want you to talk a little bit more about abortion storytelling. I see it as a vital piece of our advocacy. I know that you do too.
I do.
And I'd love for you to talk about why that is for folks who may not be familiar with abortion storytelling.
Yeah. So abortion storytelling is, like abortion itself, has been around forever, right? People tend to think about it as this new idea, this new concept. Once a reporter told me it was a trend. But the thing is that it's actually just us talking about the fact that we've had abortions, we might be considering an abortion, whatever it is. We've been doing that for thousands of years. That's how people knew, oh yeah, go to so-and-so at the hut down the street. They've got the bear root that you need, or they've got the black cohosh that you need. They have the things that you need, right? Or in Brazil, take that misoprostol, take quite a few, and you won't be pregnant anymore. That is abortion storytelling. That's how we've spread this information to make sure that we all have the care that we need and can operate under the detection of criminalization. The work that I do is more specific to kind of the more modern vision of abortion storytelling, where those of us who had abortions talk about our experiences to change the conversation so that the general public, the media, everybody who thinks they understand abortion actually understands who has abortions, why, what our experiences are, and how diverse our experiences are. I remember when I had my abortion when I was 19, I didn't think that I knew anybody who'd had an abortion. That led me to feel a lot of isolation, that led me to attempt to self-manage my abortion in an unsafe way, all of those things, because I didn't think that I could go to someone for support. So what we do is work with people who've had abortions to share their stories and really challenge a lot of the stigma that exists, even in progressive and pro-choice spaces. To this idea that abortion is always sad, or that self-managed abortion is always unsafe, things like that. When we share our stories, we really give a larger picture of who has abortions and why. And in particular, the work that we do at We Testify is to make sure that queer folks, folks of color, disabled folks, immigrants, formerly incarcerated folks, all of the folks who are usually left out of the conversation and are at increased risk for criminalization, our voices are uplifted, that we're heard loudest, because we're actually closest to the pain. So our voices and our experiences and us as experts need to be closest to the power and the vision of where we're going as a movement.
I love it. Thank you. So my last question for you, and then I want to make sure that we leave some time for folks in the audience to submit some questions, is how is the anti-abortion movement steeped in white supremacy? I know this is something that you have thought about a lot, other folks on the panel have thought about, but tell us why it's important to put this analysis at the forefront of our work on access.
Well, I can write an entire dissertation on it, and you can actually read about it in my book when it comes out in 2024. But the short version is that the anti-abortion movement has always been grounded in anti-Blackness, right? The criminalization laws of abortion, people will often say, oh, they're taking us back to the dark ages. Well, actually, abortion was not criminalized really at all. No one really thought about it until the 1860s. Well, what else was happening in the 1860s? It was actually the end of the Civil War. And of course, Black people were getting free. And of course, then that meant that their reproduction could not be used by white people for profit, for capitalism. And so, of course, then they wanted to start controlling people's freedoms and their ability to reproduce. Now, you might think, okay, but then why are they restricting abortion? Well, it's not about the specific numbers, right? It's about control and telling people that they're not allowed to decide if, when, and how to grow their families. So, of course, the restrictions on abortion have always kind of gone neck and neck with anti-immigration policies, all sorts of pushbacks against racial justice initiatives. You'll notice that as the larger restrictions have come through, it's around the same time that Black and brown people are trying to get free and that we're making gains. So of course, this is a moment where we're seeing a lot of restrictions on abortion. Also, simply because the majority of people who have abortions are people of color. We have a harder time accessing healthcare overall, consistent access to contraception, all of these things. So it is, the whole point of it is to control us and to control our ability to decide when and how to grow our families. The anti-abortion movement itself, the more modern one, started, they needed an issue to go after, particularly after they lost the ability to have school prayer and the ability to segregate schools. So they picked another issue, and Roe v. Wade actually just happened to be the issue right after all of the other things happened, segregation happened, right? So they picked an issue that they knew disproportionately would impact Black and brown people. People can become pregnant, and then of course subjugate along those same Jim Crow era lines. So they started with abortion, and then of course they used a lot of racist rhetoric in hopes that wealthy white people would just not pay attention. And that's actually what happened, and has gotten us to this point. Because as you said earlier, people kind of say, well, that's just Texas, or that's just happening to people over there. And as soon as we're willing to ignore what's happening to certain people, we seem to think that it's not going to come to us. Well, guess what? It will. It just happens to Black and brown people first. So the anti-abortion movement knows that. They know that white progressives tend to ignore what's happening to Black and brown people. So they go at us first. And so we really need people to understand that we have to undo anti-Blackness. We have to undo criminalization. Otherwise, we're actually never going to be able to have abortion at any time and any reason for everyone.
Yes. Yes, a great reminder that all of the movements are really linked, right? We can't have one without the other. So it's important for us to fight for each other in that way. I know that we are running short on time. So while we are waiting to see if there are any audience questions, I want us to do a little bit of visioning. So this fight is long, it's difficult, and it can feel isolating. So I want to know what our vision for the future of abortion access looks like. And I won't call on anybody, just whoever feels called to speak to this question. I would love to hear from you.
I can go first since we're off mute.
Yes.
I think it's just what I said, right? That everyone is able to get an abortion at any time and any reason. And that we should not have to justify our decisions. And that our decisions aren't based in coercion, whether that's because we simply can't afford children, that people should be able to have as many children as they would like to have and grow their families, and that they shouldn't be restricted by some sort of economic force or racist force, things like that. And then, of course, that making sure that everyone who's having an abortion or really experiencing a pregnancy at all, whether they're a trans person who's becoming pregnant, a young person who's becoming pregnant, that they're met with love and support. If they're an undocumented immigrant, that their pregnancy isn't treated as like just this policy issue of, met with slurs. Like, everyone's pregnancy should be met with love and support, and then they should have love and support for however they want to end it, whether they would like to parent, whether they would like to have an abortion, or they would like to place for adoption. Thanks, Renee. Any other
I
vision?
can go. I don't know that it's particularly an exciting vision, but I would really, really love for it not to be a political issue, right? I would love for this not to be a topic that we're discussing on webinars, and then I'm not trekking down to the hill to talk with folks about medical care. I would love not to have to actually talk about it at all, and that everybody get to mind their business, and that people can get the care that they need without outside pressure or interference, exactly as Renee described, and it doesn't become a political weapon for or against any community of people. Yeah.
I can add really quickly too, because I get this question I get this question often, and my simple answer is always, I want my work of having to provide practical support to be obsolete. I want these social systems, I want social safety nets, I want Medicare for all, and competent, relevant education that's accessible for all. I want, you know, universal housing that's accessible and competent and relevant for all. Like, I want these social systems to be in place so that my work isn't a direct response to the systems that are failing its communities. So it's a very long way off, but that's what I'm working towards, is that I don't have to do this anymore because people don't need it.
I will just echo what everyone else so beautifully said. Those were all of the things on my list.
Great. Well, the last thing that I will then put to you all is that I think folks might be wondering is, how can people get involved, right? What can we do? What resources exist that we can be aware of, contributing to? I'd love to hear more about that. And Renee, if you want to kick us off too.
Yeah, well, I'm a big fan of harm reduction, and just like, we all hope we're never going to get caught on fire. We all know, say, stop, drop, and roll. Well, you might not think that you or someone you know will need to self-manage an abortion, but you should know that it just takes one mifepristone pill and then 4 misoprostol pills 24 to 48 hours later in your cheeks. There's lots of resources out there, so get yourself educated. Of course, there are other self-managed methods out there, but pills is a pretty simple one for folks to know. And I think that get involved by showing up, listening to people who have abortions, and also check yourself and your own stigma. You might say, oh, you had to self-abort? That's so sad. Stop saying that. Let them tell you what their experience is. We all have our different reasons for why we do things, and actually do a bit more listening and holding up the voices of people who have abortions, rather than dumping a whole bunch of abortion stigma on them.
Down with stigma. Anyone else?
I'm going to plug the If When How Legal Helpline. I think it's a wonderful resource if you are seeking help and have managed your own abortion, or if you're seeking help and you're in the middle of a miscarriage or a pregnancy loss and you're concerned about being criminalized while seeking care. Please know that the legal helpline is out there. Understand that there is no blood test. There's no way to figure out if you have self-managed the abortion with pills, or if you obtain them through an abortion providing clinic or a clinician. And so you are able to give as much or as little information as you want and need when you're seeking care. There's also another helpline, the medication abortion helpline, that can also answer questions if you have them. Sometimes, whether you're having a miscarriage or having an abortion, you're just not sure if the bleeding is too much bleeding, if the cramping is too much cramping. There's a hotline that you can call, the medication abortion hotline, staffed with clinicians and clinical providers that can answer your questions and save you a trip to the emergency room or to your provider if you don't feel comfortable. So, there are resources that are out there that can support folks and care for yourself in the way that's best for you, while we train the doctors to stop calling the police. In the meantime, while we're doing that part too, we're doing our part. But in the meantime.
1 minute left. Any last resources we want to shout out?
Yeah, I'll really quickly go. Regarding practical support, if folks want to get involved, I would highly encourage you to, or anyone who wants to get involved, to seek out what is already existing within your communities rather than try to build from the ground up. There are people all across the country, there are groups all across the country who have been providing this care for years, and they are the experts at it. They know how to do it. They are connected with other community members. They have the resources, but they just need more people. They need more enthusiastic pro-abortion people to support them. They need more funding to do this because, as I said before, the social systems aren't there, and all of this stuff is really expensive. So first and foremost, find your local practical support org and donate, and then check them out. Ask them how you can directly support the work that they're already doing, so that you don't create more chaos and confusion by trying to build on your own.
Could not agree more. I would pull up the rear by saying, follow the lead of the frontline workers and activists who've been doing this work for years and sounding the alarm for years. Donate to your independent clinics and your abortion funds.
Yay, everyone. It was truly wonderful to have this conversation. I hope that all those in attendance learned something today, and I'll take it with you and spread it to the people that you know that are in your lives. And just thank you so much to all the folks on the panel for the work that you do day in, day out. Really appreciate you. It's a pleasure.